Hello and welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson, and I'm one of the GPnotebook study group presenters. And in this episode, I'll be discussing herpes zoster, better known as shingles. And I think it's worth starting with the underlying biology here because it explains almost everything that we see in these cases. Herpes zoster isn't a new infection. It's a reactivation phenomenon involving varicella zoster virus, which persists in a latent state after primary infection, typically chickenpox, in childhood. The virus doesn't actually remain inert in a passive sense. It hides within dorsal root or cranial nerve ganglia, essentially integrated into the sensory nervous system. And that anatomical choice is what defines the disease later in life. Now, when reactivation occurs, it's almost always a reflection of waning cell-mediated immunity. That decline may be age-related, but in clinical practice, it's often accelerated by comorbidity, immunosuppressive therapy, malignancy, or systemic stressors. And what's interesting is that in my experience, patients are rarely able to pinpoint a single trigger. And so more often, it's a gradual erosion of immune control rather than one single event. Now, the annual incidence of herpes zoster in the UK has been estimated to be between 1.8 and 4 cases per 1,000 of the population. And this increases with age, from fewer than 2 cases per 1,000 among people under 50 years old to 11 cases per 1,000 among people aged 80 or over. The incidence is higher among women as well as in people with immunosuppression, such as those with HIV or malignancies and those on chemotherapy or corticosteroid treatment. Now, once the virus reactivates, it travels along sensory nerves towards the skin. And this neuroanatomical pathway is why shingles behave so predictably in terms of distribution. The key clinical principle here is that this is a dermatomal disease. Now, that does sound straightforward, but in reality, dermatomal boundaries aren't always neatly respected, and early presentations can sometimes blur the pattern, particularly in older patients or those with atypical pain distributions. Now, before any rash appears, there's often a prodromal phase that's clinically under-recognized, and approximately 70 to 80% of patients with shingles present with pain in the dermatome, where skin lesions then subsequently appear. And patients may describe burning, deep aching, or electric shock-like pain confined to a narrow band of skin. And some will have marked sensitivity to light touch, even where clothing can become uncomfortable. And this is neuropathic pain, driven by inflammation within the affected ganglion and nerve root. And at this stage, it can be very easy to misattribute symptoms to musculoskeletal disease, radiculopathy of non-viral origin, or even visceral pathology depending on the dermatome involved. And this is one of the reasons why it's in this prodrome stage that diagnostic uncertainty is highest. A thoracic distribution may mimic cardiac or gastrointestinal pain. Cervical involvement can be mistaken for cervical radiculopathy. Lumbosacral presentations may be attributed to mechanical back pain. And the absence of a rash is what makes this phase clinically challenging. And we mustn't forget too that 1 in 5 patients present with systemic symptoms such as fever, headache, malaise, or fatigue. And then, typically within 48 to 72 hours, the cutaneous phase declares itself, and the evolution of lesions is fairly characteristic here. What begins as erythematous macules rapidly progresses to papules, and then grouped vesicles on an erythematous base. The lesions tend to appear in clusters rather than a continuous sheet, and they evolve in successive crops over several days. The unilateral distribution still remains one of the most reliable clinical clues here, and the midline is usually spared, which remains a useful bedside discriminator. As far back as medieval times, this was known as the belt of roses from hell, and for some patients, this is an apt description. Then, over time, the vesicles rupture, crust, and eventually heal, usually within 2 to 4 weeks in immunocompetent individuals. But resolution of the skin doesn't necessarily correlate with resolution of symptoms. And this is where the disease often becomes less visible, but more clinically significant. Now, pain is central throughout the illness, but its nature evolves. So, during the acute phase, it's inflammatory and neuropathic combined, and patients often describe it as severe, sometimes disproportionate to the visible rash, and in older adults, this can be particularly debilitating and resistant to simple analgesia, to the point where it isn't uncommon for patients to require escalation beyond standard non-opioid options, at least temporarily. A particularly important clinical subgroup here is those at risk of post-herpetic neuralgia. Now, this isn't simply persistent pain. It represents sustained neuropathic dysfunction after the acute infection has resolved, and the likelihood of this occurring increases with age, the severity of the acute pain, and involvement of cranial dermatomes, particularly the ophthalmic branch of the trigeminal nerve. Unfortunately, once established, this pain can persist for months and sometimes significantly longer, with a major impact on quality of life. And cranial nerve involvement actually deserves special attention here because it introduces complications beyond pain alone. So when the ophthalmic division is affected, there's a risk of ocular involvement, including keratitis, uveitis, and in severe cases, even visual impairment. And the presence of vesicles on the tip of the nose is often discussed as a clinical warning sign of the risk of ocular involvement. And this should prompt a lower threshold for ophthalmology assessment. Another clinically important variant is Ramsay-Hunt syndrome, which occurs when reactivation involves the geniculate ganglion. And in this scenario, patients present with a combination of facial nerve palsy, otalgia, and vesicular eruption around the ear or auditory canal. Vestibulocochlear involvement may lead to vertigo and hearing loss. And compared to idiopathic facial palsy, recovery tends to be less complete, which makes early recognition and treatment particularly important. Now, oral shingles is another presentation that's sometimes missed. When trigeminal branches supplying the maxilla or mandible are involved, vesicles may appear on the palate, gingiva, or tongue, and these lesions can ulcerate quickly. So what is seen clinically may already be erosive rather than vesicular. But the key diagnostic clue here remains the unilateral distribution, often confined to one side of the oral cavity. But unsurprisingly, misdiagnosis as a dental infection isn't uncommon, and it can lead to unnecessary dental procedures before the underlying cause is finally recognized. Now, in immunocompromised patients, the spectrum of this disease broadens significantly. Disseminated zoster is defined by widespread cutaneous involvement beyond the primary dermatome and adjacent segments, and in these cases, the virus may not remain confined to the skin and can involve internal organs, leading to hepatitis, pneumonitis, or even encephalitis. And these are the patients in whom shingles shifts from a self-limiting neurocutaneous condition to a potentially life-threatening systemic infection. Neurological complications can also extend beyond the skin. So because the virus resides in sensory ganglia, it can occasionally involve motor pathways or central nervous system structures, and this can result in cranial neuropathies, myelitis, aseptic meningitis, or, in rare cases, encephalitis. Now, although these are uncommon, these complications are very clinically significant and do tend to occur in patients with impaired immune function. So from a diagnostic perspective, most of our cases are identified clinically, but laboratory confirmation does become useful when the presentation is atypical, such as when it's necessary to differentiate genital zoster from herpes simplex, or to diagnose herpes zoster pain without any skin lesions being present, known as zoster sine herpeti. PCR testing of lesion fluid is currently the most sensitive method and has largely replaced older techniques. Direct fluorescent antibody testing can also be used in some settings, while a Sank smear remains of historical interest but does lack specificity and is now rarely used. Serology, particularly IgM, does have limited utility in isolation for reactivation disease. Now, as you might imagine, the differential diagnosis here is broad, particularly in the early stages of the disease. Herpes simplex can occasionally present in a dermatomal-like distribution, although recurrence patterns and lesion morphology do usually help distinguish it. Other vesicular or inflammatory conditions, including contact dermatitis, impetigo, insect bites and drug eruptions, may also be considered depending on the context. And importantly, when the pain precedes a rash, non-cutaneous causes must also remain in the differential depending on the anatomical location. The management here is most effective when it's started early, and antiviral therapy remains the cornerstone of treatment, ideally started within the first 72 hours of the rash onset, and they're used to reduce viral replication in all patients, especially in those who have severe disease, are over the age of 50, are immunocompromised, and who have evidence of trigeminal nerve involvement. Administration of agents such as acyclovir, valacyclovir, and famciclovir shorten the duration of viral shedding, stops the formation of new lesions, prevents ocular complications, and reduces the severity of pain. Now, while their impact on preventing post-herpetic neuralgia is less absolute, there is evidence of benefit, particularly in older patients and those at higher risk. One systematic review of high-quality trials found that famciclovir and valacyclovir were superior to acyclovir in reducing the likelihood of prolonged pain, and pain control requires a flexible approach here. So looking at the antiviral adult doses, these are typically with acyclovir, 800 milligrams 5 times a day for 7 days, continuing for 2 days after crusting of lesions in those who are immunocompromised. With valacyclovir, this is 1000 milligrams 3 times a day for 7 days, or with famciclovir, 500 milligrams 3 times a day for 7 days, 10 days in immunocompromised individuals, or 750 milligrams once or twice a day for 7 days. Now, in mild cases, standard analgesics may suffice, but many patients do require escalation due to neuropathic pain characteristics. And in acute, severe cases, much stronger analgesia may be necessary. Adjunctive topical therapies, such as lidocaine, can provide localized relief, And in persistent post-herpetic neuralgia, longer-term neuropathic pain strategies, including topical capsaicin or other agents, are often required depending on the clinical response. Lotions containing calamine may also be used on open lesions here to help reduce pain and pruritus. We should always keep in mind secondary bacterial infection, especially when lesions are excoriated or in patients with poor skin integrity. And in such cases, topical or systemic antimicrobial therapy may be appropriate. And it's also worth reminding here that prompt referral to an ophthalmologist is required for all patients who have eye manifestations. Finally, I think it's worth placing shingles in a preventative context. Vaccination strategies targeting varicella zoster virus have become an important tool in reducing both incidence and severity, particularly in older populations. Herpes zoster vaccine is effective in preventing herpes zoster disease. The shingles vaccine is well tolerated and produces few systemic adverse events. It's known to last at least 3 years, and revaccination isn't usually considered necessary. And there are 2 shingles vaccinations available, Shingrix and the live attenuated Zostavax vaccine. So from a public health standpoint, this has begun to shift the epidemiology, but in our day-to-day clinical practices, shingles remains a common and sometimes underappreciated cause of significant neuropathic morbidity. So I'd suggest that herpes zoster is best thought of not simply as a rash illness, but as a reactivation of a neurotropic virus within a sensitized nervous system. The rash is often the visible part of a much more complex neurological process. And for us as GPs, the challenge lies in recognizing the early pain syndromes, anticipating any complications based on distribution and host factors, and treating our patients early enough to meaningfully alter the disease course. So that's a very quick overview of herpes zoster, and I do hope you found this podcast helpful the next time you see a patient with shingles. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.